you about the scariest patient you'll ever see in the ED. She looks so innocent, but when a precipitous delivery comes into the emergency department and then the neonate is sick, it's terrifying, unless you know what to do. So today, I'm going to talk to you about the most essential parts of neonatal resuscitation, specifically for the emergency medicine physician. The good news is, most neonates come out doing just fine. About 10% require some form of support, but will ultimately do well. It's only about 1% of neonates that require true resuscitation, but that 1% is what we train for. And that's going to be my focus today. The most important thing for you to take away from my talk is that in neonatal resuscitation, airway is paramount. Most neonatal arrests occur secondary to airway compromise. So your most important step, always, 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 is to focus on airway and breathing before anything else. The first thing you do when the baby comes out, we all know, is to suction. You want to clear out the secretions from the airway. Then you move on to warming, drying, and stimulating the baby. And the truth is, that's all most neonates will need. Then you move on and you assess the airway. And this is when you turn and really look at the baby. Are they breathing well? Are they blue? Are they limp? Are they apneic? If you have any concerns about their airway, you move on to provide positive pressure ventilation with a bag valve mask. While one provider is assessing and addressing the airway, have a second provider assess the heart rate. This is best done by auscultating over the chest, as I've shown here with the stethoscope. And the provider who's listening should tap out the heart rate on the bed so everyone at the bedside can see what's going on with that provider's hearing. You're really looking for a heart rate greater than 100. If the heart rate's greater than 100, you're good. If the heart rate is less than 100, then you need to intervene. And it's the same intervention as when you're concerned about the airway. You BVM the kid with positive pressure ventilation. If the heart rate is less than 60, this is a coding baby. Your first move is still to provide positive pressure ventilation with a BVM. But what you need to know is that if the baby does not respond within 30 to 60 seconds, then you're moving on to intubate and starting chest compressions really quickly. So this is a key number, heart rate less than 60. So as I've said, the most important piece in any problematic neonate is that you're delivering high quality breaths at a physiologic rate. That's about 30 to 40 breaths per minute. And it's so important that the breaths that you're giving are high quality. I'm going to spend a minute to talk to you about what you can do to optimize the breaths you give. If you're a mnemonic person, you're in luck. There's a mnemonic for this. It's Mr. SOPA. The M stands for mask adjustment. So your first step when you're adjusting the airway that you're giving is to improve your C and E hold. You can see that my knuckles are white here in this picture. It takes a lot of effort to deliver high quality breaths and get a good mask seal. So focus on this first. The R stands for reposition the airway. Remember, babies have huge occipits, so you probably need to place a shoulder roll or tilt the head to achieve an optimal sniffing position. S stands for suction. So you can suction again with that bulb suction, or you can use a deep suction device to clear out the airway and help make sure you clear out the secretions and can get the breath in. O stands for open the mouth. You can either do this manually or add an oral airway, so again, your breath can get all the way into the baby. And P is the most important piece of this mnemonic. It stands for pressure increase. Babies have a lot of physiologic changes that are happening at birth, and pressure will help open up and pop open the alveoli. So on your BVM, you need to make sure that you have a PEEP valve, and you need to turn that PEEP valve up even to 20 so you can help pop open the alveoli. And A stands for airway alternative. So if you've done all these steps and your baby's not responding, you're still concerned about their airway, or their heart rate is still less than 60, it's time to intubate. Don't wait. So what size laryngoscope do you want? What size endotracheal tube do you call for? If you feel like this, you're not alone. It's hard to remember these sizes in the middle of a room like this, and especially in the middle of a stressful neonatal resuscitation. You might be sitting there thinking you remember a formula. You might be thinking of this formula for an uncuffed ET tube 4 plus age over 4. But if you're having trouble recalling it now, you're going to have a lot of trouble in the middle of a difficult resuscitation. So I suggest that you assign one of your team members to be the Broslow tape person, to pull out the Broslow tape and be the person you turn to whenever you need a size or dose in a difficult resuscitation. So we figured out airway. What do we do next? We've intubated the patient. It's time to reassess the heart rate. Again, the provider should listen over the chest and tap out the rate so the whole team can see. If the heart rate is still less than 60, it's time to start chest compressions. The optimal technique is shown here, this 2-thumb technique. Just like in adults, you're aiming for greater than 100 compressions per minute. But it's really important to allow for full chest recoil between each of the compressions. And unlike in adults, it's super important in neonates to coordinate your compressions with your breaths. So the compressions you give are 3 compressions per 1 breath. So that's 1, 2, 3, breath. 1, 2, 3, breath. And this is all important because the most important piece of what you're doing is getting air into the baby. So you want to give those breaths in between compressions and make sure you're still giving high quality breaths at a physiologic rate, even though you're doing compressions. Once you're in a full resuscitation, this is when you think about access. The best way to get access in a neonate is an umbilical vein catheter, or UVC, which I have shown here. But if you're not familiar with the procedure of placing the UVC, or you don't have one of these handy in your emergency department, you can always use an intraosseous line. And then you're going to reach for medication. And just like adults, you're reaching for epinephrine. But again, it's going to be difficult to remember the dose of epinephrine in this code. So turn to your Broslow tape person and provide a safe dose of epinephrine for this neonate. The last piece of neonatal resuscitation you want to think about is that some babies arrest because of hypovolemia. In that case, you can consider giving a fluid bolus or a blood transfusion. And those are really all of the essential pieces to neonatal resuscitation. Hopefully, with everything that you've done, you get your baby safe to the NICU for definitive care. I want to take a minute to thank all of my amazing mentors at ALL New York City, at Sinai, my awesome class of 4th-year residents, and my 2 nieces who posed for a lot of pictures.
All right, gang, we're going to take a break shortly, but not yet.